Hi, my name is Sarab Sodhi, and I'm the Director of Undergraduate Ultrasound at Cooper Medical School. What we're going to talk about today is a brief introduction to what POCUS, or Point of Care Ultrasound, is, and why we think it's important and you should learn how to do it. So first and foremost, we're going to make a slight differentiation between what point of care ultrasound is and what a comprehensive ultrasound is. Now, the distinction between those two is that point of care ultrasound is when the clinician is worried about the patient, wants to do a test at the bedside that will give them immediate information and answer a simple series of yes and no questions. So, what the clinician does in that setting is they will simply bring the ultrasound machine to the patient, do the study, and interpret it immediately at the bedside. And that ends up looking sort of like this, where the clinician's there doing the study and making their decisions. If, on the other hand, they have a more expansive question or they need more information than a simple bedside test would help with, then what they would end up needing to do is essentially putting an order into the computer, sending the order over through, for example, at Cooper, through Epic. The order through Epic populates through about 4 different computer systems, ends up on the radiology tech's queue. Radiology tech will put in for a transport person to come collect the patient, or they put them on their own queue if it's a portable study, and they'll bring their ultrasound machine up in the next hour or so. They would do the study at the bedside. They would send the study over to the radiologist. The radiologist would interpret the study and send the interpretation over to the treating clinician. So the simple differentiation between the two is that obviously a point of care study is a lot quicker. You simply bring the machine over. The only thing limiting your ability to do the study is your own time, versus a bunch of other systems that have to be used. But before you think that a point of care study is always superior to a radiology study, bear in mind that there is a difference between what you're answering when you do a limited point of care study or a comprehensive radiology study. So for example, if you are doing an echo, which is typically done by a cardiologist, this is what the questions at a point of care echo can answer. There are usually about 4 or 5 of them. And is there an effusion? Is it EF normal? Is there inequality? Look at exit, look at entry. And these are all yes/no questions, right? Is the exit abnormal? I could read. Or, is the IVC small? Yes, no. Versus for an echocardiogram, you can see that there is a large number of other pieces of information that come in here. There's various measurements. They're looking at different portions of the septum. It's a much more granular study. It takes significantly longer and it adds a ton more information. Now, that's sort of the other word that's used as a comprehensive or limited. You can call a point of care study a bedside study. There's a lot of other euphemisms that can be used. One of the things that typically people don't like to do is to call a comprehensive study a formal study, because the semantics are that it implies that your study that you do at the point of care is limited. Now let's talk through some cases where it actually helps a lot. So this is a great one. We see this frequently. Patient is brought in by EMS. The EMS crew tells you that they're short of breath, they have a history of COPD and CHF. They bring them into the emergency department, you're looking at the patient. Your lung exam is not particularly helpful, the patient's not sure what it feels like, or they look very sick. There is excellent data showing that even better than doing an x-ray and getting some blood tests, including a proBNP, a better test to do is to look at their lungs with bedside ultrasound and look and see if there is any evidence of interstitial edema. That test has a far higher sensitivity, far higher specificity, and it helps you immediately figure out what's going on. So rapidly you can make the decision about which treatment direction to go through. Let's talk about another case. You're on the floors in the middle of the night, covering the medicine service, and you get paged to place an IV. The most experienced nurse has tried and has attempted to place the IV, and they've tried 4 or 5 other times. You have placed 0 IVs in your lifetime, or you've placed 2. Versus a nurse who's placed thousands, but somehow you have to do it. Using an ultrasound and having been appropriately trained on it means that your likelihood of success will skyrocket compared to placing landmark, especially after an experienced person who's placed many more IVs than you ever will has failed at placing it. Let's talk about the next one. You're working in the OBGYN office, and you have a young woman who comes in excruciating abdominal pain, and you don't know exactly what's going on with her. A bedside ultrasound to see if there's free fluid in the abdomen and or an ectopic pregnancy can be life-saving. Let's go through the next one. You have a child who presents to your outpatient pediatrics office and presents with an area of cellulitis that has a little fluctuance. It could be an abscess. You could try to drain it, but if there's nothing in there, that's an unnecessarily painful procedure for no benefit. Or you could give her antibiotics and treat her with those, but not necessarily know what's going on. But with a magical ultrasound machine, what you can do instead is you can look and see if there is a fluid collection that needs to be drained. And if that fluid collection needs to be drained, then you can arrange for her to get that drained appropriately. Whether that's through a radiologist, or whether that's through a surgeon done in the outpatient setting, or whether that's through the OR, or whether that's just done at the bedside with you giving the patient a little analgesia. Whatever ends up being necessary and appropriate. And the reason all of this comes in handy is because each of those situations is one that we see very frequently in each of those settings. And let's say you get summoned to the bedside on the surgical service, and one of your post-op patients has just collapsed and is having CPR done on them. And you're not sure if the patient has a pericardial effusion because they just had thoracic surgery. You're not sure if they have a pneumothorax, a hemothorax. You're not sure if they have potentially just a pseudo-PEA and their heart's actually still beating. You just can't feel it. You could look, and if you look, you could find it and treat them accordingly. And those skills are easily transferable and easily expandable. Procedural topics are another area where ultrasound is critical. There is extensive data arguing now, especially after some landmark trials, that placing a central line like one of these without an ultrasound into the internal jugular vein is probably akin to malpractice in this day and age. There's really no reason one should be doing that because there's significant data showing that your risks of causing a arterial puncture, pneumothorax, any of those bad things is near zero when you use an ultrasound and you're adequately trained. There is a lot of anecdotal and some very less robust evidence that doing ultrasound-guided paracenteses, thoracenteses are much safer when you use ultrasound. There's significant data that doing ultrasound-guided nerve blocks is safe and effective for pain control. Same thing with ultrasound-guided pericardiocenteses when needed. And then we already talked about ultrasound-guided IVs. So the purpose of this conversation was to remind you guys that ultrasound is a critical tool for every single specialty that I can think of. And there are situations where you will end up needing to use a bedside ultrasound, or if you knew how to use a bedside ultrasound, you could take better care of the patient. Now, yes, I know that we have been practicing without this tool for thousands, hundreds and thousands of years. However, it's a good idea for us to embrace new technologies, especially if they make you a more competent clinician. And what you'll discover as we go down this journey and start to do this is that it'll help augment your history and physical skills. It'll help give you a way to get a little bit more information at the bedside, and it'll make you a more judicious user of imaging. Because you'll realize that not everything can be solved with an imaging test. You'll realize that not everything needs an imaging test. And most importantly, you'll realize that sometimes you find incidental things, and maybe that test was more harm than it was help. So I'm going to leave you with this. Now, this is a very revolutionary statement by the American Medical Association. And this makes the argument that there is no particular specialty, not obstetrics and gynecology, not cardiology, not radiology, not emergency medicine, that own ultrasound. Ultrasound is a diagnostic tool that can be used by any clinician who has the adequate training and adequate expertise in performing it. Now, bear in mind that doesn't mean that willy-nilly every single one of you can pick up an ultrasound and start just using it on patients. There should be some degree of quality control. There should be a process. There has to be hospital credentialing. There's still lots and lots of bureaucracy. But this remarkably revolutionary statement basically makes the argument that if you want to start using ultrasound, you, within your specialty, have to build a process and an agreement in a way that you can do so safely and for the best care of the patient. And the reason I leave you with this statement is because this is back from the 1990s, when the American Medical Association realized how much of a difference this makes in daily practice, and how helpful it can be for your education, your learning, and your practice to be able to do these things. Okay, so this was just a brief introduction to how ultrasound can be used, where it can be used at the bedside, and where it is often very, very helpful. We are going to come back and have a bunch more conversations. We're going to have a conversation about physics and knobology that I promise is going to be physics light. We're going to have a conversation about each of the core content topics. And if you're ever wondering how all of this works, you can always reach out to me. My email is my last name, SODHI, @rowan.edu. Thanks, and have a good day.